Welcome back to NerdMDs StackBytes, where we turn one of our latest Substack posts into a 10-minute power session. This allows our subscribers to listen to a discussion about recent content to further digest our NerdMDs content. We are here for you readers and listeners. The link to the Substack article will be in the show notes. Sit back and relax and enjoy this most recent NerdMDs StackByte.
Welcome to the deep dive. Today we're embarking on, well, a pretty crucial journey into the future of healthcare. If you've ever felt like the system is just trying to patch endless leaks, you're absolutely not alone. Our source material today, some really powerful excerpts from Dr. Adam Carew's Health Delivery 2.0, Rebuilding Healthcare's Foundation, doesn't just suggest changes. It argues pretty urgently that it's time to stop patching and actually start building anew.
Indeed. And Dr. Carewe frames this moment as a kind of burning platform. He argues that the financial realities aren't just pressures anymore, they're almost existential threats. He proposes this pretty radical demolish and rebuild approach, shifting from what he calls sick care, where you mostly just treat illness.
The reactive stuff.
Exactly. Shifting to genuine health delivery, focusing on keeping people well in the first place. And what's fascinating is he sees this not just as like a strategic choice, but as an urgent necessity for survival, really.
Okay, let's unpack that. Why swing the wrecking ball now? Dr. Carewe really zeroes in on some stark financial realities. Seems like that's the big driver here.
He points directly to the Centers for Medicare and Medicaid Services, CMS. They recently announced a pretty significant cut, negative 2.9% to the 2025 physician fee schedule. And at the very same time, healthcare expenses are just rocketing upward, inflating at CPI plus 5.
Wow. Okay, so what is that combination shrinking revenue, soaring costs? What does that truly mean for providers and, ultimately for us as patients?
Well, it means that margin hacking, all those little incremental cost cuts are trying to boost volume. That's effectively dead. The core insight really is when revenue is shrinking and expenses are exploding, you can't just tweak the edges. The whole economic engine needs a radical overhaul. That's why Dr. Carewe's mantra is model redesign lives. The old ways, they just won't survive. And he lays out 6 big structural moves that, every operator clinician, every fearless rebel, as he calls them, should be thinking about right now, which raises this really important question for all of us. How fundamentally do we need to rethink how healthcare is delivered and, maybe most importantly, paid for?
Okay, let's get into those 6 moves. The very first one on his whiteboard, kill fee for service. Completely dismantle it. He says the volume game is officially on hospice. It's quite a phrase. And that Medicare's carve-outs, those reductions, they just keep carving away. Making the RVU bonus, that's the relative value unit, how docs get paid for volume, feel like Schrodinger's paycheck.
Mm-hmm. Yeah, it's a great image, isn't it? It captures the uncertainty. And if you connect this to the bigger picture, this move is really about flipping the entire margin equation, completely turning it on its head. Instead of billing for every little service, Dr. Carewe suggests swapping those RVUs for what he calls population health upside.
So wait, just to clarify, you're only compensated if a whole group, like an entire population, stays healthy. That's a massive shift in incentives.
That's precisely the idea.
Yeah.
A massive shift. It also means kind of automatically eliminating visits or encounters that don't actually shift risk or improve outcomes, and crucially, bundling chronic care codes into one clean PMPM. That's per member per month payment. So the takeaway for any healthcare operator is pretty stark. Your margin, trying to squeeze that out, it won't save you. Your model will. It's like replacing a rickety staircase that charges you per step with an elevator that only moves when the whole building's health improves.
Okay, that makes sense. Which leads right into the next point, doesn't it? Yeah. If you kill fee for service, what replaces it? And his answer, pay for risk, not visits. Seems like the logical follow-up.
Yeah.
So how much traction is this pay-for-risk model actually gaining out there? Is it happening?
It really is gaining significant traction. Dr. Carewe notes that capitation, that's the fixed payment per patient, remember?
Regardless of visits.
Exactly. That now touches about 14% of U.S. healthcare spend. Yeah. And what's really striking is that this is basically double what it was just 4 years ago. He also highlights these specialists in data analysis, he calls them actuarial linguists, who are finding these big utilization deltas, basically finding major efficiencies, sometimes up to 20%, in how resources are used.
Okay, so practically speaking, what does this mean for healthcare organizations? What do they need to do?
Well, this move really calls for mastering REF mechanics. That's the risk adjustment factor, which adjusts payments based on how sick a patient population is. Essentially, your coding, your medical documentation, because it's incredibly crucial. It's directly tied to your bottom line, your EBITDA. It also means seriously front-loading prevention, because every hospital admission you avoid, that equals pure retained margin, pure savings, and critically important, sharing the win with the clinicians, giving them some downside protection, but also a real upside pop if they manage risk well. The message is pretty clear. Beat the risk curve or get steamrolled by it. There's no tie game here. No tie game.
Oh. Wow, that's a powerful statement. Really underlines it. This isn't just about finding efficiencies. It's about survival, really. Survival and relevance in this new world.
Absolutely.
All right, move number 3, make data liquid. I like that phrasing, that line, data hoarders. That's until 2010. It really jumps out. Speaks to a huge frustration for everyone involved. What's driving this push for data to flow like Venmo transactions, as he puts it?
Well, the biggest single driver is probably the January 2025 TEFCA rule. That's the Trusted Exchange Framework and Common Agreement. It's designed to create a single on-ramp for health info exchange across the whole country. And it hardwires this nationwide exchange using FHIR. That's Fast Healthcare Interoperability Resources. Basically a standard to help different systems talk to each other easily.
Okay, so it makes sharing easier.
Much easier. But the rule also comes with some serious teeth. We're talking penalties of like $1 million per blocked record, per instance of blocking. So it really forces the issue around, who truly owns the data and patient access in this digital age.
Gotcha. So what's the actual blueprint then? How does Dr. Carewe suggest making data flow that freely?
Well, first, he stresses, unblock all your data and do it in 90 days. Because compliance is just way cheaper than the fines and the a PR nightmare of getting caught blocking. Then it's about adopting open APIs. Those are the things that let software talk to each other, building everything on FHIR, exposing the endpoints so data can be accessed, and enabling real-time data swapping. And finally, pushing analytics to the edge, so running things like risk scoring right inside the app at the bedside, not, hidden away in some back-office silo somewhere.
Makes sense. Bringing the insights to where they're needed. Okay, move 4. Regulated code speed. This sounds very much about technology, AI, that sort of thing. But what does it mean for how fast things can get approved and used, especially when the tech itself keeps changing?
Exactly. It means a pretty fundamental shift in how we regulate. The FDA's new guidance on living algorithms means that adaptive AI that learns and changes over time can actually get clearance for healthcare use. Mm-hmm. But, and this is a big but, it comes with incredibly strict conditions. The old way of approving something static just doesn't work for AI that's constantly evolving.
Right. So what does it take then for an AI tool to get that clearance and, crucially, stay compliant?
Dr. Carewe suggests you need to version control every single weight update. That's every time the AI model learns and adjusts itself, like you're shipping vaccine lots. Total traceability. You also absolutely have to bake in explainability. You can't have black box AI making decisions nobody understands. It just won't survive post-market audits.
It needs to be transparent.
Completely. And it requires running a continuous validation loop. He describes it as CI/CD meets clinical safety board. So continuous software development practices, but with a constant clinical safety check. He really hammers this home. Transparency equals clearance. Opacity being a black box. That equals 483 letter hell, which is a very serious FDA warning letter you do not want to receive.
Understood. Okay, move 5. Shift care home first. This is a trend we've definitely seen picking up speed, right?
Yeah.
Especially lately. Dr. Carewe says remote monitoring plus AI triage has flipped home-based primary care from being just a skunkworks like an experiment to a real backbone. The vision of the couch as the new ward, it's evocative. I can almost picture it, though hopefully without tripping over the dog toy, like you said. But seriously, how do we actually make that work logistically, financially?
Yeah, the vision is compelling, isn't it? Clinical excellence being sort of teleported right into the living room, making home the default when it's appropriate, of course.
So how do they propose making that big shift happen? What are the concrete steps?
It really boils down to 3 key mandates. First, mandating 0 config sensors shipped at discharge. So patients just use Bluetooth, no complex setup, nothing to plug in. Easy. Second, staffing a 247 command center, have a nurse practitioner queue use algorithms for escalation so there's continuous monitoring and a fast response if needed. And third, and this is critical financially, billing hospital-at-home DRGs. Those are the codes for inpatient stays. So you capture the full hospital reimbursement, but deliver that complex care safely and effectively right in the patient's home.
Right, capturing the value while shifting the location.
Yeah.
Okay, last one, move 6. Retail keeps us honest. This feels very driven by the consumer experience. We're talking big names, Amazon, CVS, plus these newcomers promising, one-click, same-day, transparent price care. That's a different standard.
It absolutely is. And Dr. Carewe believes that healthcare systems that just can't match that level of service, that consumer focus, they'll inevitably be reacquired, replatformed, or just flat out replaced. It really raises that big question. Who's going to ultimately control healthcare delivery down the road?
So the advice for the traditional players is basically copy them. Borrow their playbook.
Precisely, yeah. He suggests aiming for appointments scheduled in under 60 seconds. Meds delivered to your door tonight, mirroring that retail convenience factor. Also, turning your EHR, your electronic health record, outward. Make it patient-facing, super easy to use, zero friction getting into the portal. Think online shopping cart, ease of use. And finally, he advises studying the M&A tape, looking at the mergers and acquisitions happening in retail and tech, because retail capital is hunting every fat margin blind spot in traditional healthcare. They see opportunities. The warning is pretty stark. If you can't beat Prime, become Prime for Health, or partner up fast.
Okay, so those are the 6 big monumental shifts, a lot to take in. But for someone listening thinking, okay, where do I even start this demolishing and rebuild? Where does Dr. Carewe suggest beginning right now?
He gives 3 immediate actionable starting points. First, plot your risk runway. Figure out exactly how many PMPM lives, how many patients under that per member per month model you can safely manage realistically within the next 12 months.
Know your capacity for risk.
Exactly. Second, open the pipes. Map out every single data silo you have in your organization, and then set a hard 90-day OKR objectives and key results to get that data unblocked and flowing. And third, restage your site of care. Commit to moving just one DRG, one type of hospital care to the home setting this quarter, just one to start, then aim for 3 more next quarter. Prove the model, build momentum.
Got it. Start small, prove it, scale it. It really sounds like a blueprint for a complete overhaul, doesn't it? With that core message, smash, sweep, and rebuild.
That's the essence of it.
Well, this deep dive into Health Delivery 2.0 makes it incredibly clear. The future of healthcare, at least in this vision, isn't about small tweaks. It's fundamental structural change. It's about moving beyond just reacting to sickness, that sick care model, to genuinely paying for and proactively prioritizing health.
Right. And the financial pressures, combined with these rapid tech advancements that Dr. Carewe outlines, they present huge challenges, no doubt, but also really unprecedented opportunities for innovation. The core idea, as he puts it, is that the studs are showing. The underlying framework is exposed, it's failing. And it's time to frame a future that actually pays for health and wellness.
So, thinking about this radical vision, what stands out to you listening right now? Do these ideas resonate with your own experiences, or maybe they spark totally new questions about how we access care, how we pay for it? We really encourage you to think about how these kinds of profound shifts might impact you, your family, your community in the coming years. And maybe ask yourself, what studs are showing in your own corner of the healthcare world that signal it might just be time for this urgent rebuild?
Thank you for listening to Efficiency Unlocked, Nerd Tested, MD Approved, a NerdMDs podcast by Drs. Adam Carewe and Dale Gold.